Okay, thank you everyone for being here today. We are extremely grateful to have Dr. Redmond back to give us an update on COVID. To introduce Dr. Redmond very quickly, she is a professor in the Department of Epidemiology and Biostatistics at SLU and the director of the Institute of Biosecurity. I was able to get that without stumbling on that. So she's delivered great presentations on the state of COVID for us in the past, and we're really grateful to have her back. So with that, Terri, I will hand it off to you.
Great, thanks. Okay, so of course, I'm going to talk today about COVID-19 pandemic, the current state of the pandemic in terms of what we're seeing and potentially where we're going. So I'm going to describe what's happening with the current epidemiology, describe some clinical implications about what we're seeing with the current variants that are circulating, discuss whether this is endemic versus pandemic, which seems to be a controversial topic. And then I'm going to, as always, try to predict the remainder of the pandemic. So let's start by looking at what's happening in the United States in terms of COVID. This is the entire epi curve from the start of the pandemic until now. And as you can see, we've had a number of different pandemic waves. The biggest wave being last winter, so winter of 21-22. That's when Omicron first hit the United States, and we had a record number of cases, record number of hospitalizations and deaths, all tied to COVID-19. Since that time, rates have come back down, although we have seen a couple of different waves. Everything that we have seen since fall of 22 to fall of 21 has all been related to Omicron, different variants of Omicron. So it has still continued to mutate and change over time, but it's all been tied to that initial Omicron variant. What we're seeing right now, we've seen steady declines in rates since mid-January. So we did see a fall and winter wave this year, much smaller than what we saw last winter. And we've just seen steady declines ever since then. When we look at Missouri, what we're seeing, case rates and hospitalization numbers are very low at this time. So we are considered to be in a low community risk level. And that's true across most of the state. There are a couple of areas that continue to be in a medium risk level, but we're not seeing very high hospitalization rates and mortality rates like we were seeing at other times during the pandemic. One thing to keep in mind, though, our surveillance data has become less accurate over time. So what's happened, there's basically two kinds of COVID-19 tests. There's a rapid antigen test, and then there's a PCR test. The rapid antigen tests are really only accurate when you have symptoms. The PCR tests are more accurate, but they're a little more expensive. They take a little bit more time to get results back, generally speaking, and fewer people have access to those because they tend to be more expensive tests. None of the at-home rapid tests are included in any of the data that's being reported by public health agencies, either locally, regionally, nationally. So none of those rapid tests are included in any of our data. So what ends up happening is we're only seeing those PCR test results, which means we're really only seeing the tip of the iceberg. So when you look at case rates or you hear about case rates, just keep in mind that they are probably significantly higher than what you're actually seeing because so many people test at home and none of that data is reported publicly. So in terms of what's currently circulating in the United States, as I said before, we've been seeing different subvariants of Omicron for over a year now. So Omicron continues to evolve, and so it has different subvariants under Omicron. So right now, so if you look on the right, this chart shows you by week the percentage of the variants that are causing identified illness. So you can see back here in December of last year, there was a lot of BQ 1.1, BQ1, which were also in some BA5 left over. Those are all subvariants of Omicron. And then you'll see it started to take over. XBB 1.5 really took over. And so now, and for the past 6-8 weeks or so, XBB has been causing most of the disease in the United States that we're identifying. So XBB, again, subvariant of Omicron, very highly transmissible. It's even more transmissible than other Omicron strains, and Omicron in general is more transmissible than Delta or the Alpha variant or any other variant that we have seen. So it just spreads very, very easily from person to person. All of the Omicron strains and XBB in particular are also a little more challenging because they are able to evade vaccine-induced immunity. So you can be vaccinated, you can be up to date on vaccination, which I highly recommend that you stay up to date on vaccination, but the Omicron strain is able to evade some of that vaccine-induced immunity. So when we look at what COVID-19 as a disease currently looks like, it's a range of illness from mild to severe. Generally speaking, Omicron is a more mild disease, especially compared to earlier in the pandemic and especially compared to the Delta variant. But even just the whole range of symptoms in general, we have shifted from this being more flu-like illness to almost more like a cold for most people. Now, not everyone. We do still see severe illness. We do still have hospitalizations. There are still people who are dying from COVID. But in general, the average person who gets infected with COVID-19 right now will have very, very mild symptoms or no symptoms at all. So the two main symptoms that we're seeing right now with COVID-19 for the average person would be cough and or a sore throat. So that those early symptoms like loss of taste and smell, very, very rare with Omicron. People can still have it, but that used to be kind of that hallmark symptom. Like if somebody lost their taste or smell, we knew you have COVID-19. We're really not seeing that anymore. We're not seeing as much of the shortness of breath, difficulty breathing in general, because again, this tends to be a very mild disease at this point. Now, part of the reason why this is true, why we have shifted from what used to be a more severe disease to in general being a more mild disease, is that vaccines are now available. Many people have received at least some doses of vaccine. Many people have been infected by COVID-19, sometimes multiple times, and we have much better treatments now. So all of this means that in general, COVID-19 is becoming a more controllable disease, and it's having less of a health impact at a public health level in a community. Doesn't mean we don't still have severe disease, doesn't mean that we don't have people that are still getting very sick, requiring hospitalization or dying, but in general, it's having less of an impact over time. So what we're primarily seeing now is that there are a limited number of groups that tend to have or be higher risk for severe illness. So again, the average person getting infected with Omicron has very mild disease, but there are a group of individuals that tend to have more severe illness. Those are individuals that have never received any vaccine, any doses of vaccine, individuals who are immunosuppressed for any number of different reasons, individuals that have underlying health conditions, and the top 3 risk factors for severe illness from COVID-19 are obesity, diabetes, or having heart disease, and simply being over the age of 65, regardless of any other underlying health condition. Individuals who are over the age of 65 are at higher risk for severe illness. So long COVID, I'm sure all of you have heard the term long COVID. Long COVID is a syndrome pattern, a pattern of symptoms that are long-term effects after someone has recovered from COVID-19. We don't know exactly how long COVID lasts. We are still studying this. It appears that it can last for weeks to years. Individuals that develop long COVID, you're more likely to get long COVID if you had severe illness. In particular, if you were ever hospitalized with COVID, you are significantly at higher risk for having long COVID than someone who had COVID and recovered without ever requiring hospitalization. Individuals who had never received a dose of vaccine are at higher risk for long COVID, and individuals that have underlying conditions such as obesity, diabetes, and heart disease. But we are seeing some cases of long COVID even after someone has recovered from mild illness. So we're not able to completely predict who's going to develop long COVID. We also don't have a great list of symptoms of like, this is the condition that is long COVID. So there's still some controversy about exactly what constitutes long COVID. So there are some primary care providers who will call a syndrome or a set of symptoms long COVID that doesn't meet the same criteria somewhere else. So even if you look at the websites of different healthcare systems, Mayo Clinics doesn't match what Hopkins is saying, doesn't match what BJC is saying. So there's just differences when you look at, we don't have a standardized definition of long COVID, in other words. So in terms of how COVID-19 is transmitted, it's transmitted from person to person by infectious respiratory particles. The way that you get exposed is by being close to somebody who's infected. The original definition was 15 minutes or more when you're not wearing a mask. They think because it's so transmissible at this point, it doesn't require 15 minutes of exposure, but we don't have a great definition of X number of minutes constitutes an exposure at this point. We do know that the highest risk for exposure is if you live with someone who has COVID-19. So household members, we call those, we consider those individuals to have a continuous exposure, meaning they're sort of constantly being exposed to COVID-19. That puts you at increased risk of developing COVID-19 yourself. Another way that you can be exposed is just having a short-term direct contact with respiratory secretions. So should someone cough or sneeze on you directly, that also constitutes an exposure to COVID-19. In terms of treatment for COVID-19, there's two essential buckets of or categories of treatments that are currently available for individuals who are infected. There's antiviral therapy, and then there's monoclonal antibodies. Antiviral therapy essentially stops the virus from multiplying in your body. You need to be started on it sooner rather than later. So as soon as you get diagnosed, if you're eligible for antiviral therapy, you need to start on that right away. It needs to be within 5 days of the onset of your symptoms. Monoclonal antibodies work a little bit differently. They help the immune system recognize and respond to the virus, just like other antibodies. They work in the same pathway in the body. Similar to antiviral therapy, that the sooner you start it, the more effective it's going to be. So as soon as you get diagnosed with COVID-19, if you're eligible to get monoclonal antibodies, you would need to start on that right away, within 7 days of becoming symptomatic. Both antiviral therapy and the monoclonal antibodies have both been shown to reduce severe illness and hospitalization rates. Across Missouri and across St. Louis, we now have test to treat centers. So you can call the 800 number on the slide, or you can Google it and you can find a place where you can go, you get tested. If you're positive, they could start you on antiviral therapy right away. In general, the monoclonal antibodies, it's more complicated to receive the monoclonal antibodies. So I just recommend, if you're high risk, talk to your primary care provider if you test positive, and they will get you in touch with the correct treatment that's going to work best for you. I assume all of you have heard at the federal level, the public health emergency, the declared public health emergency that is COVID-19 is ending effective on May 11th. So there's a lot of questions among people about why the public health emergency would be ending, considering globally, we are still in a pandemic. So the pandemic has not ended. However, what the US government has said is that we are now in a new phase of the pandemic, which is absolutely true. We are at a place where we have better access to treatments that are more effective than we had earlier in the pandemic. We have access to better vaccines, and vaccines are basically available to anyone who wants them. And we're seeing less severe variants. So the disease is becoming more mild over time, and we just have better treatments and better preventive measures at this time. So the US government feels like we no longer need to consider this a public health emergency, and we're moving more towards treating this we're learning to live with COVID-19. It's also true that many or most of us at this point have what we call hybrid immunity. So there's two kinds of immunity. There's vaccine-induced immunity. So you get vaccinated and your body develops a certain level of immunity against that disease. Then there's natural immunity, which is when you get exposed to a disease and you get infected and your body develops antibodies against that disease. So those are two different kinds of immunity within your immune system. Hybrid immunity means that you have both. That means that you have been vaccinated and you've also been infected at some point. And so you have both kinds of immunity working for you. So because so many people have been infected with Omicron or COVID-19 at some point, and since most individuals have received at least one dose of vaccine, most of us have hybrid immunity at this point, which means that when we are exposed to COVID-19 again, or for the first time, your body has some immunity, some level of immunity against it, which means you're not going to have as severe of disease. So we know that things are going to change. It's not completely clear exactly what's going to change after the public health emergency ends. There's still some things that are up in the air. So we're not exactly sure what's going to happen in terms of testing and insurance coverage. But what we do know is likely to happen is that the price of COVID-19 tests is probably going to go up. It's unclear if insurance is going to continue to cover COVID-19 tests or if they'll only cover rapid tests versus PCR tests because the rapid tests are cheaper. It might be different depending on which kind of insurance you're on or whether you're on Medicaid or Medicare. There might be a charge for vaccine at the federal level. So right now, and since the vaccine first became available, the government bought all of the vaccine and provided it free of charge to everyone in the US. Moving forward, that might not be the case anymore. However, in St. Louis City and St. Louis County, both of the health departments plan to continue to provide free COVID-19 vaccine because they do still have some COVID funding. So at least in the St. Louis region, you should still be able to receive free vaccine even after the middle of May. So in terms of how to protect yourself from COVID-19, since we are shifting to a new phase of the pandemic, our mitigation strategies have really changed. If you think about where we were a year and a half ago, where we had quarantine in place, we had universal masking in place, we had just a lot more restrictions in place. We're really now in a new phase, and we're starting to look more like the pre-pandemic time. So you have to take different steps to protect yourself now because we don't have some of those risk mitigation strategies in place at the public health sort of community level. So the two most important things that you could do to protect yourself are to stay up to date on COVID-19 vaccination and to choose to be masked if you're going to be in public spaces, especially when infection rates or community risk levels are high. So let's talk about what has changed over time in terms of the pandemic and why things are changing, why things look different, and why our mitigation strategies have changed. So when the COVID-19 vaccine first became available, our goal was to try to vaccinate as many people as possible and to reach what we call herd immunity. So herd immunity is the concept that you don't have to vaccinate 100% of a population to provide protection against a disease. If you vaccinate more than, and it's different for every disease, but somewhere between 75 and 90-something% of individuals, if you vaccinate a large number of individuals, the people that are unvaccinated have protection because there's no one susceptible around them. So the goal when the vaccine first became available was to reach herd immunity and then end the pandemic. We also wanted to prevent as much transmission as possible. We wanted no disease spread from person to person. Now our perspective has really changed. We have realized that it's probably impossible to reach herd immunity through vaccination alone. And that's because the Omicron variant and other subvariants have learned they are able to evade vaccine-induced immunity. So vaccine is great at preventing severe illness on the individual level, but it doesn't necessarily prevent infection, and it doesn't stop disease transmission from occurring. So it's not going to be easy to reach herd immunity at this point with vaccine alone. Our other goal, rather than trying to prevent as much transmission as possible, our goal is to have society be as normal as possible while still minimizing severe illness, hospitalization, death, and impacts on our healthcare system. Other things that have changed over time. So SARS-CoV-2 is the virus that causes COVID-19. The virus itself has evolved over time. As I said before, Omicron is much more transmissible, but it's much less severe as a disease in general. And it has evolved to the point where it can evade most vaccine-induced immunity. But most of us have some level of immunity. Natural immunity because we've been infected, vaccine-induced immunity because most of us have had at least one dose or more doses of vaccine, or hybrid immunity, those of us that have both. So now let's talk about the COVID-19 vaccines and where we're at. So right now there's, as of today, and this could change tomorrow, we have the primary series of vaccine, and then we have booster vaccine. So the primary series of COVID-19 vaccine is a monovalent vaccine, meaning there's just one variant against which, one strain of COVID-19 against which that vaccine works. So it's against one variant, in other words. So it protects against the alpha or the original strain. That's the primary series. For the mRNA vaccine, it was a 2-dose series, or the J&J vaccine was a single, and Novavax was considered just a single dose. The booster vaccine is that newer vaccine that's bivalent, meaning that it protects against 2 different variants. It protects against the original alpha strain and also Omicron, and specifically within Omicron, it protects against BA4 and BA5, which are no longer circulating in the United States. So they were circulating last summer, last fall, but now we're seeing XBB 1.5 and XBB in general. So the bivalent vaccine is not even as protective as it could be if it had different strains in it. So if we look at the vaccine effectiveness with the primary vaccination series, so that's that monovalent vaccine. This is the vaccine series that most of us received. Now it's been over a year ago or longer, year and a half ago for most people. That was that single, the vaccine against that single strain, that original circulating strain. What we're finding is that that vaccine is somewhat effective for a short period of time, but it has limited protection against Omicron, XBB, and XBB 1.5. And if you received the primary series more than 6 months ago, which almost everyone at this point has, you have almost no immunity left from that primary series at this point. The primary series is more effective at preventing severe illness, hospitalization, and death compared to just preventing you from becoming infected in general. The more recently you received it, the more protective it's going to be. So if someone did not get vaccinated right away and they waited until, let's say, fall, and they didn't get the primary series until fall, they would actually have more protection against severe illness compared to those who got it as soon as the vaccine became available. Now, when we look at the booster vaccine, that's the bivalent vaccine. So it covers that primary, the original strain, plus the Omicron strains, BA4 and BA5. The booster vaccine does provide some protection against XBB and XBB 1.5. If you get it, like right after you get the booster vaccine, it will minimize your risk of infection for about 3 months. And everybody's immune system's a little bit different, so it's hard to say exactly how long you're protected, but protects you against infection for about 3 months. But better, it gives you strong protection against severe illness, hospitalization, or death for an extended period of time. We don't know exactly how long, and as new strains continue to evolve, we constantly have to be looking at when did you get vaccinated and how well does that protect against severe illness with what is circulating right now. So it's kind of this moving target in terms of our epidemiology data and looking at vaccine effectiveness. So the current COVID-19 vaccination recommendations, and this is as of today. And the reason why I say this is totally in flux. So the FDA had a meeting, I believe in January, to talk about moving away from the monovalent vaccine, that primary series, and instead moving towards using only the bivalent vaccine. And the FDA had some recommendations that they came out with. The CDC has not yet adopted those, but they probably will at some point, probably this summer. So that's why I say, like, this is true today, but again, I don't know when the CDC is going to change the recommendations. Could be as soon as tomorrow. So as of today, the current recommendation is that you get that primary series with the monovalent vaccine, and then you get a single dose of the bivalent booster. Now, the FDA has said, let's not use that monovalent vaccine at all, because we know it doesn't work as well against Omicron, which is currently circulating, and just give bivalent vaccine. They also suggest that we move away from this primary series and a booster vaccine to just going to once a year, everybody gets the bivalent vaccine, and then we just choose which strains are in that bivalent vaccine every year based on what we expect will be circulating. This is the same model that we use for flu vaccine. So with flu vaccine, we look at what happened in the Southern Hemisphere and what was circulating there. We use that to decide which strains are going in the flu vaccine. We make the flu vaccine, then we have the flu vaccine available in the fall. And the flu vaccine is different every single fall. So that's what the FDA is recommending in terms of COVID-19 vaccine. They also say, however, even if we do move to an annual vaccination, that there might need to be some targeted structures towards helping people who are high risk. So high-risk individuals, high-risk groups might need 2 doses of vaccine every year as opposed to just 1 dose. Very similar again to what we do with flu. We have a high-dose flu vaccine or we give 2 doses of flu vaccine every year to some individuals that are in high-risk groups. Again, this is just what the FDA has recommended. CDC has not adopted any of that. So the CDC right now is still sitting with that, get the primary series, single dose of bivalent vaccine. So there are a lot of things that we don't know about vaccine moving forward. We don't know if or when a new variant of COVID-19 is going to emerge, has the potential for being more severe. So we could potentially have something that looks more like the Delta variant. It's unclear if our current vaccine would be effective against a new variant. We never know until something has evolved. There might be some kind of impact when we lift the federal public health emergency order, but we just don't know yet because the government just has not released a lot of information about what exactly that's going to look like. And we don't know what the CDC is going to do in terms of shifting towards an annual vaccination approach. Again, I think they're most likely going to move towards that risk-adjusted approach of saying, if you're a high-risk individual, then we recommend that you get more than 1 dose in a year, and everyone else just get the 1 dose of the bivalent vaccine every year. But again, I don't know, I can't read the CDC's mind, so I'm not sure exactly where they're going to land with their recommendations. So in terms of mask use, vaccination and mask use, so the 2 primary mitigation strategies you can use personally to protect yourself from infection. So mask use in public. So we know that in general, the more people that are masked, the better, the more protected we are as a society. So when we have universal masking in place, that's the most protective masking approach that we can use. We also know that who's wearing the mask matters. So if the high-risk person is wearing a mask, that's good protection, depending on the kind of mask that they're wearing. But if the infected person is masked, that's actually better. But we don't always know who's infected because people have very mild disease. People can have no symptoms at all and still be infected. So unless we're going to walk around with everyone masked all the time, it's just difficult to be able to know exactly who needs to be masked in terms of trying to identify those with COVID-19. Again, the best protection is if everybody is masked. So universal masking is going to be the most protective measure that we can take in terms of masking. What the CDC has said in terms of masks use is that universal public masking needs to be based on the community risk level. So they divide community risk levels into 3 levels: low, medium, and high. Low is where most of Missouri is at now, as I talked about earlier. There are a couple areas that are at a medium risk level. And then right now in Missouri, we don't have any high community risk levels. So the CDC says if a community is in that high risk level, or when a community is in a high risk level, then you should consider using universal masking. Now that's the CDC recommendation. CDC doesn't have the authority to require people to be masked at this time. And so it's up to local public health departments. What I can tell you about St. Louis is that there were times when we were in a high community risk level and we did not have universal masking in place. And I think it would be very difficult at this point to move back to universal masking unless something drastic happens with this pandemic. The community as a whole has kind of moved away from this concept of universal masking. The advantages of this current approach of basing it on the community risk level is that means that it has shifted to personal responsibility. So everyone personally gets to choose whether or not they want to be masked and what kind of mask they want to wear. And it reserves universal masking for those times when we have really, really high risk levels in the community, where we have high hospitalization rates, a lot of severe illness, big impacts on healthcare systems. The disadvantage to this approach is that if you wait until you're seeing really high community risk levels, then it's kind of too late to do a lot. The universal masking is going to help, but it actually would have been better if you would have done it closer to the medium risk level to try to cut down on some of that transmission before we actually reach that high risk level. Because we know universal masking is more protective. And we know that letting individuals decide if they want to be masked really does not protect the vulnerable people in our community as well as universal masking would protect them. If you are going to choose to be masked, just keep in mind the mask or respirator that you choose is very important in terms of the level of protection it's going to provide you. Masks are divided into 2 different categories. This is like from a healthcare regulatory standpoint. There are masks and then there are respirators. Respirators are a type of mask, but they are actually considered their own category. So when we talk about masks from a healthcare perspective, we're talking about cloth masks or surgical masks. Cloth masks are the least protective, even when they're tight fitting. Cloth masks, if you're going to choose to wear one, really need to be multiple layers and they need to be very, very tight fitting to the face. You're better off getting a surgical mask and making sure that it's very tight fitting to your face. That's going to be more protective than a cloth mask. Even better, if you can tolerate it, would be wearing a respirator, either a KN95 respirator or an N95 respirator. These are the most protective kinds of masks that you can wear. They filter much better. They filter smaller particles. They protect better against COVID-19 spread. But the respirators, because they are so tight fitting and because they have better filters, they're more uncomfortable. So they are hotter to wear. Some people report they have difficulty breathing in them. So in terms of what's going to happen next with the pandemic, it's hard to tell exactly. We've never had a pandemic with a coronavirus before, so it's impossible to predict exactly what's going to happen. We might have another summer wave. We have had a summer wave every previous summer. So in my mind, it makes sense that we would see another wave this summer. It's much more likely that we're going to continue to see a wave every fall and winter, at least until this either goes away or just continue to see fall and winter waves, kind of like we do with flu every year. So in terms of whether this is endemic versus epidemic meaning outbreak, many of you have probably heard on the news There are some epidemiologists, or there are some people who are claiming to be experts who are saying that we have moved into a point where we are no longer in a pandemic and we have now reached the endemic stage of this disease. The formal definition of whether a disease is endemic means that you have a constant pattern of disease, you have very predictable patterns of illness, and that disease is not causing disruptions to daily life. That means you either have low transmission levels or you have no transmission levels, or it might be seasonal, kind of like with flu. Epidemic, on the other hand, is when you see a sudden increase or higher than expected rates for a specified time in a specified place. The common word, much more common word for epidemic, is outbreak. So the factors that affect moving from a pandemic or an outbreak to being an endemic state is whether or not you have things like, do we have a new strain of illness? So what we're seeing right now, as I said before, is Omicron, XBB, and XBB 1.5. Now, we might get a new strain. It's very likely we're going to get a new strain of SARS-CoV-2 at some point. Where did these new strains come from? Well, either they come from an existing strain, like XBB can continue to mutate, and you might see a minor change. Usually that means that the virus is becoming less severe. Or you can see a major change in that virus structure because it either reassorts or it evolves into a whole new strain. That's a major change in a virus. So what we've seen with SARS-CoV-2 as a virus so far is we've seen both minor and major changes in that virus. So we saw Delta versus Omicron, that's a major change in the virus, versus BA1 to BA5 to XBB. Those are all considered just minor shifts in that particular virus. If a disease has an animal reservoir, meaning that the virus can survive in an animal and in humans, then that means that you're much more likely to have a disease that's going to continue to cause periodic outbreaks or lead to pandemics, because that can lead to virus mutation, because the virus, it can circulate in animals and can change within the animal itself. There's also then that potential for disease transmission from animals to humans. When we look at SARS-CoV-2 as a virus, it does have animal reservoirs. So animals can be infected with COVID-19. Companion animals, dogs and cats, can get infected with COVID-19. Animals in zoos have tested positive for COVID-19, like some of the big cats, tigers and lions, otters, non-human primates, hippos, and other animals. And also wildlife. So white-tailed deer, anteaters, minks, and other animals have also tested positive for COVID-19. However, when we look at the risk of animal to human spread of COVID-19, we found that it's very low. In general, people are getting infected from COVID-19 from other humans. So we're basically spreading it to each other versus the animals spreading it to us. Another factor that affects whether this is an outbreak versus becomes endemic is how well we're able to control the disease on a global level. So while it's able to spread globally, and while it continues to spread globally, the virus is going to continue to mutate within the human host. So even though the United States might have COVID-19 under control for now, for a while, if it is spreading wildly in other countries, then that virus is able to mutate within those humans, develop new variants, and then those could be imported back into the United States. So there was the risk of this this winter. There was a large increase in cases in Asia. So there was some concern that because there were so many new cases, that maybe it was a new variant, and we were really afraid that that variant was going to come to the United States and cause another massive wave. So we do have to keep an eye on what's happening globally, because it does have an impact on what happens here to us in the United States. Vaccination coverage globally is also really important because, again, this leads to how susceptible the humans are in other countries. So if vaccination is provided to other people outside of the United States, and if there's a lot of vaccine uptake, that means there's less opportunity for that virus to infect humans and mutate in them, develop new variants, which are then imported to the United States. And then vaccine effectiveness is also really important. So if we can find a vaccine that is really effective against the circulating strain, we could potentially reach herd immunity. We haven't been able to do that yet, but we could. So the big question is COVID-19 currently endemic? Some people will tell you yes. If you actually look at the definition of from an epidemiological standpoint, it is not currently endemic. We are still in an outbreak. We are still in a pandemic. But it's likely that at some point COVID-19 is going to become endemic in the United States. But it's also likely that it'll be endemic with sporadic outbreaks. So what is most likely to occur is that we'll reach a point where it's very low levels of disease, and then areas that don't have great vaccine uptake, or a new variant will pop up, or every fall and winter we'll just see a new outbreak of COVID-19. That's what's most likely if you look at what has happened with flu outbreaks, assuming coronavirus is seasonal the same way that flu is seasonal. That's what it's most likely to look like. So our goal is really to limit severe illness, prevent healthcare systems from being overwhelmed, and try to develop vaccines that are effective against whatever is circulating at that time. So it is very likely that we're going to need to have annual COVID-19 vaccines, just like we do with flu. So I would anticipate that this is the direction we're moving in. Again, I cannot predict exactly what's going to happen with this pandemic, but I think that's the most likely place that we're going to land in terms of this pandemic. So when we do, let's assume we move to an endemic state, and then we suddenly have a COVID-19 outbreak. What is that going to look like? Well, then we will need to respond to that outbreak. So an outbreak is an increase in severe illness or a large healthcare surge. So what that means is that, so right now we have very few mitigation strategies in place. We don't have universal masking. We're not quarantining. We're not requiring people to be tested. We just encourage people to be tested. So what we might need to do during outbreaks, so let's say we have a very large outbreak next fall or winter, if we have a huge impact on the healthcare system, then we might need to temporarily put some of those mitigation strategies back in place. So we might need to move back to universal masking for a short period of time. We might need to have a longer isolation period. We might need to require testing. So all of those restrictions that we had in place earlier in the pandemic, you can think of them as like tools in our toolbox, right? So we have the tools, we know what works. We just need to decide which tools we want to use during a future outbreak. One of the biggest challenges I think we're going to face with this particular pandemic, even if we move to an endemic state with these periodic outbreaks, is that so many people have reached that point of pandemic fatigue. And we're also dealing with the politics behind this pandemic. So people are tired of the restrictions. They are tired of universal masking. They don't want to be required to get vaccinated. Again, politics definitely play a role. So it makes it very difficult to put some of these mitigation strategies back in place, even though we know that those tools work. So hopefully, when it is time to put those tools back in place, hopefully citizens will get behind those and do the right thing so we can cut down on severe illness. So what I hope you learned today, we're still in a pandemic. We're absolutely still in a pandemic. Most protective measures you can take are to stay up to date on vaccination and mask when you're in public places.
Okay, well, thank you, Dr. Rebmann. Are you ready for some of the questions that were in the chat?
Absolutely.
Okay, so we had someone wanting to know regarding the K95 respirators. Do you have any advice for recognizing if they're fake or not?
The CDC has a great website that lists legitimate KN95s that you can go and link to. It's very complicated and it's kind of a moving target because there are some countries that make KN95s very inexpensively and they're not up to par. So I would go to the CDC website, and if you just type in respirator or KN95, it'll take you to that website that will tell you which are legitimate ones and which ones you might want to steer away from.
Thank you. And then we have, when do you anticipate the availability of the new bivalent? This person had their bivalent in September 2022.
That's a great question. So what I expect is going to happen is that sometime this summer or maybe late spring, the CDC is going to adopt some or all of the FDA recommendations, and they're going to decide what strains need to go into the vaccine to be ready for fall. I don't know exactly when they're going to do that. My guess would be May, June, July-ish. And then they'll make the recommendations. They'll build that vaccine and have it available for individuals early in the fall.
Thank you. Marilyn, you had your hand up, and then Norman, you'll be up next.
Okay, if I miss, if you did say this, stop me, but I don't remember. Could you discuss the drug, if I'm pronouncing it right, Paxlovid? I don't know if I am, but I just read an article the other day where they considered it sort of a miracle drug, and that why is it just limited to certain ages, and what restrictions? I mean, I know you shouldn't be on a cholesterol medicine, I don't think, when you take it, but could you discuss that drug a little bit?
I can tell you a little bit. So I'm not a physician, and I don't prescribe the antiviral therapy. So I'll tell you what I know, sort of big picture. So Paxlovid is one of the antiviral medications. There are only certain high-risk groups that have it, that they are eligible to receive it. If you take it early on, it should reduce severe illness such as hospitalization and death. It does have some side effects. I mean, no medication, no vaccine is perfect. One of the primary issues with Paxlovid that I'm aware of is that you can have a rebound infection. So you can take Paxlovid, recover from COVID, test negative, and then suddenly develop symptoms again, within like a week of stopping the Paxlovid. And then you have to isolate again and basically start over. But in general, Paxlovid is supposed to be, what I've read is that it's very effective at limiting severe illness. So even if you have rebound infection, it's still better to have Paxlovid and have mild illness than to have severe illness and end up in the hospital.
Okay, thank you.
Norman, you had a question? Oh, go ahead and unmute. You'll get the prompt on your screen.
Yeah, my question was answered. I raised a question about availability of the next bivalent, so thank you.
Oh, I was Norman Solomon. I think
Oh.
you're unmuted now, so go ahead.
Yeah, I was on mute, sorry. When you consider that the severity is now dropped off, and people just are kind of ignoring it now, the whole issue, they don't want to think about it. Within the healthcare community, who keeps track of when some new strain comes along so they can take precautions against it and decide that it's time for people to get a different booster? Who looks after that kind of information?
Yeah, so that's on the public health side. So the CDC monitors which strains are circulating, and they do that by they gather data from across the United States. So each of the states submit samples, a certain percentage of samples, to the CDC that looks at what strains are causing disease in that particular state. So the CDC keeps an eye on that to look at like what's circulating right now. And then they also look at what is associated with that particular strain. So how severe is the illness with that particular strain? So as things start to change, it's a combination of sort of public health and then the healthcare side that look at what strain are we seeing right now and how severe is that illness. And then based on that, decisions are made about what kind of mitigation strategies make the most sense in healthcare and then also for the general public.
Is that similar to what's done with the flu vaccine every year?
Similar in that the CDC, there's a group of experts that look at what is circulating in the Southern Hemisphere because they have the opposite winter. So what they are seeing circulating for flu is what we put into the vaccine for our upcoming flu season. So they try to guess or estimate what they think is going to be circulating, and that's what they put into the flu vaccine every year.
Okay, thank you, Marcia. You'll be up next. We had someone in the chat though put in, how effective do you think memory cells, in parentheses B cells, are for the early strains?
So I'm not an immunologist. I think it's a great question. We're really not sure exactly. Well, now the early strains aren't even circulating anymore. So no one's being exposed to the alpha strain or the gamma strain or any of the earlier strains at this point, because we're only seeing Omicron. So I don't know what would happen if suddenly the alpha strain reemerged somehow. I don't know how our immune systems would respond to that.
Thank you. Marcia, you had your hand up.
Yes, and I'm sorry, I don't know how to get my hand up otherwise. Is it true that Great Britain and Canada are already offering a second bivalent to their population?
I'm not sure. I wouldn't be surprised. They tend to be a little, we don't always follow the same recommendations.
I read that, but I never know what you read is correct or incorrect. So
yeah, I haven't really been following what the other countries are doing. I've mostly been kind of keeping track of what the CDC is recommending for us.
thank you.
Okay, anybody have any last questions? I know Dr. Rebmann has to, an appointment at 11, so we have time for maybe one or two more. Okay, well, I think you answered everything, Dr. Rebmann. We really, really appreciate your presentation today. Delivered a lot of great information. Just really want to thank you.
Sure. Thanks for having me.
Thank you. And if everyone wants to stay on real quick, we have a couple of upcoming programs I like to promote. On April 4th, we have Ken Weintraub here. He is going to be doing the Jewish history of the NBA, which should be really interesting. And we also have a great program with Sheldon coming up. So Sheldon, I'm going to unmute you. Would you like to talk about that for a little bit?
Am I unmuted?
Yep, I can hear you, Sheldon.
Okay. So with the Holocaust Remembrance coming up once again in another month or so, it might be interesting to revisit Europe, Poland in particular, in terms of what it looked like and what Jewish life looked like prior to the Holocaust. Unique in 1939, Life magazine was going to run a story on Jewish life in Poland. Poland was at that point in time the second largest Jewish community in the world, second only to the United States. And the Jewish life had really changed in Poland from what was once a society that was oriented to shtetls, which is where many of our grandparents came from, to a very urban lifestyle as a result of the Industrial Revolution that took over in Poland after World War I. And it was amazing footage that Life magazine took in terms of the quality of what was going on in Jewish communities in 5 major cities in Poland. Unfortunately, before the story was run, the Germans invaded. And the story was, therefore, Life never published the story or any of the footage that they took. I have that footage, and that's what we're going to show in, what's the date?
April 18th.
Okay, on April 18th, I will share with you the footage from the Life magazine's work in Poland in 1939, and it will bring back to our memory and consciousness the quality of Jewish life that existed in Europe prior to the Holocaust and some understanding in terms of just what was lost.
Excellent. Thank you, Sheldon. And that will be in person, just to be clear, to let everyone know, at 10 a.m. So if anyone wants to sign up, feel free to email me or give me a call. So thank you, Sheldon.
Sure.
Okay, well, thank you everyone for coming today. So with that, I'm going to wish everyone a good day.
Thank you.